and fine needle aspiration cytology. Regarding this investigation, fine needle aspiration cytology, there is limitation in follicular adenoma. It diagnoses the nodule as follicular tumor. It cannot differentiate between follicular adenoma and follicular carcinoma. Why? Because follicular carcinoma is diagnosed on the histopathological background. There should be vascular invasion, capsular invasion, mitotic figures. So this cannot be diagnosed by fine needle aspiration cytology. Treatment of follicular adenoma is by lobectomy and mastectomy. This operation we called it hemithyroidectomy. Let us now talk about carcinoma of thyroid gland. And we start with the predisposing factors. The most important predisposing factor is external radiation to the neck. Also, long-standing simple multinodular goiter. And presence of other thyroid lesions like Hashimoto's thyroiditis, usually predisposed to papillary carcinoma or to lymphoma, follicular adenoma predisposed to follicular carcinoma. Also, there may be a genetic predisposition. This may be visualized in patients with papillary carcinoma, and there may be mutation of the red proto-oncogene. This diagram or this table show different types of thyroid cancer: papillary, follicular, anaplastic, medullary, and comparison between these tumors. Regarding the etiology, we can see there is the radiation is the most important predisposing factor for papillary, and follicular tumor. The most important predisposing factor is the endemic presence of endemic goiter. Anaplastic unknown, medullary sporadic, maybe sporadic or familial. The incidence it is about 60% in papillary, 17% in follicular, 13% in anaplastic, 6% in medullary. Regarding the age of onset, usually in papillary it is between 20 to 40 years, and follicular between 30 and 50 years, anaplastic 50 years and above, medullary in middle age. Another point of comparison between these tumors is that when we diagnose these tumors, usually the papillary is thyroid swelling with lymph node metastasis, and follicular thyroid swelling with bony metastasis, and anaplastic thyroid swelling with local fixity and stridor, while medullary carcinoma is difficult to diagnose clinically. Microscopically, we find there is a special cell with special characteristic nuclei. We call it orphan I nuclei. Orphan Annie I nuclei. Orphan Annie is American cartoon character with characteristic eyes that simulate to the nuclei of malignant cells in papillary carcinoma. You can compare between these eyes and orphan eyes, between these nuclei, and orphan Annie eyes. Also, we can see there is samoma bodies. We call it samoma bodies. While in follicular carcinoma, we may find there is angio invasion and capsular invasion. And in anaplastic carcinoma, usually there is a poorly differentiated sheet of cells. In a medullary carcinoma, amyloid stroma-like carcinoid. The separate of these tumor is by lymphatic separate in papillary, blood separate, hematogenous separate in follicular mainly, local infiltration mainly in anaplastic, while in medullary carcinoma it is lymphatic and hematogenous separate. Regarding the investigation, fine needle aspiration cytology is highly accurate in papillary tumor, while in follicular tumor we need frozen section or the piece of thyroid that is removed during surgery. while in anaplastic carcinoma, fine needle aspiration cytology is also of great benefit, and incisional biopsy. We may remove the isthmus and send it for histopathological examination. Medullary carcinoma also fine needle aspiration cytology is of benefit, and the calcitonin tumor marker considered in medullary carcinoma. In follicular carcinoma, as we can see, there is no mention for fine needle aspiration cytology. As I mentioned to you, it cannot differentiate between benign tumor and malignant tumor. Regarding the treatment of this tumor, in papillary, near total or total thyroidectomy, similar to that in follicular carcinoma, while in anaplastic, usually we find this tumor in advanced stage. We need only palliative treatment in form of osmosectomy regarding the surgery, and we add to this treatment external radiotherapy, while in medullary carcinoma, the main line of treatment is by total thyroidectomy. Regarding treatment of metastasis, functional neck dissection in papillary carcinoma, while radioactive iodine or external radiotherapy in follicular carcinoma, and palliative external radiotherapy in anaplastic, and radical block dissection in medullary carcinoma. TSH dependence. In papillary and follicular, there is TSH dependence, while there is no TSH dependence in anaplastic and medullary. Hormone production, very rarely for papillary and follicular carcinoma to produce hormone, so rarely to be thyrotoxic, very rare. Well, there is no hormonal production in anaplastic, while in medullary there will be secretion of calcitonin and 5-hydroxytryptamine and ACTH. Regarding the prognosis, it is excellent with the treatment in papillary carcinoma. It is good in follicular carcinoma. It is the worst in anaplastic and bad in medullary carcinoma. We can see this picture for papillary tumor, and we can see that usually the spread is lymphatic spread to the adjacent to the prelaryngeal and paratracheal lymph nodes. In anaplastic carcinoma, usually there is invasion, local invasion to the adjacent tissue. Regarding the clinical picture of thyroid carcinoma, the type of patient. In papillary carcinoma, commonly female around 15 years old with thyroid swelling in the neck with lymph node with enlarged lymph node. While in follicular thyroid carcinoma, female around 40 years of age with rapid progressive swelling in the neck at some time with the skull metastasis. While in anaplastic carcinoma, commonly a female, old age female, complaining of rapid progressive swelling in the neck with hoarseness of voice. While the symptoms, there is a swelling in the lower part of the front of the neck with malignant manifestations like rapid increase in size with short duration, pain related to swelling, or referred to ear due to involvement of Arnold nerve, which is a branch from the vagus nerve. Also, there may be symptoms of infiltration according to the organ that infiltrated. When it infiltrates the trachea, there may be dyspnea. esophagus, there may be dysphagia, which it is rarely to involve the esophagus. Sympathetic chain, there may be Horner syndrome, which involves ptosis, meiosis, enophthalmos, and hydrosis. Involvement of carotid artery, postural fainting. Involvement of internal jugular vein, edema of the face. Involvement of recurrent laryngeal nerve, maybe hoarseness of voice if unilateral, stridor, bilateral. And also features of metastasis, commonly to liver, bone, lung, brain. What are the signs that can be detected? On general examination, there may be features of distant metastasis to the bone, there may be hepatomegaly, there may be skull mass. Local examination, there will be swelling in the lower part of the front of the neck, which is tender, hard, irregular, fixed, and there may be buried sign. The sign is absent of carotid pulsation, and there may be lymph node enlargement, and these lymph nodes usually hard. At first it's mobile, then become fixed. Also, regarding the clinical presentation of thyroid, there may be atypical presentations, like sometimes we find just there is enlarged lymph node in the neck, and there is no primary in the thyroid, detectable primary in the thyroid. This is called lateral aberrant thyroid. Another atypical presentation with thyrotoxicosis when there is functioning carcinoma, and this is very rare. Also, when there is simple nodular goiter that have low-grade tumor. And there may be histological surprise. What we mean by